Good evening to everyone and welcome to today's session. In the initial part of nephrology, we have reviewed ARF versus CRF, indications of dialysis, which are all the essential part of the management of a case of renal failure. Now we are going to dwell into the various forms of glomerulopathies, tubulointerstitial disease, cystic diseases of the kidney, renovascular disorders and the malignancies of the kidney, and say goodbye to the subject of nephrology. To walk immediately into hematology is going to be our next chapter for the discussion. So we welcome our online students at Anantapur, Kurnool, Jabalpur, everywhere. Now what are the various primary glomerular disorders? Glomerulopathies are broadly divided into primary and secondary. We have a minimal change disease whose most common presentation is nephrotic syndrome, and it is very common in the children. The minimal change disease need not always be idiopathic. Even the people who have Hodgkin's lymphoma, they can react, their kidneys can react with the minimal change disease and can lead to the development of a nephrotic syndrome like presentation is what need to be remembered. Why it's called minimal? It's called minimal because if you do light microscopy, there is no hypercellularity, there is no interstitial inflammation, there is no glomerular basement membrane thickening, nothing is seen. All nephrons look as such, they are good children. But what is the problem? If you take the electron microscopy, the foot processes, where do you find foot processes? Bowman's capsule has got a parietal and a visceral epithelium. The visceral epithelial foot processes are obliterated, which is the underlying problem in the people who have minimal change disease. Prognosis is excellent, and if you give steroids for 4 to 8 weeks, most of these people will respond. Sometimes they will keep having relapses. This is how a child who is in an acute phase of nephrotic presentation, after giving steroid therapy, completely improved is what you are able to clearly see. Now whenever you have a glomerulopathy, always the discussion is it can present like a nephritic syndrome or a nephrotic picture. Summarize the differences between nephrotic syndromes is one of the favorite short answer question in the tomorrow's final year exam. So doctor, why nephritic syndrome occur? When there is a lot of inflammation with the cellular infiltration into the glomeruli will lead to nephritic picture. There is no cellular infiltration, but the glomerular basement membrane's permeability got altered, then that leads to nephrotic syndrome. Nephritic classically is found in post-streptococcal glomerulonephritis, which is the most common underlying cause, whereas nephrotic syndrome can be due to many reasons. It can be idiopathic, it can be due to underlying lymphoma, SLE, drugs, and conditions like SLE, drugs and infections, any of them can lead to. The classical example is Plasmodium malariae. You know, Plasmodium has so many species. Malariae, how can it present? It can present in the form of nephrotic syndrome. So there is a reason infections can lead to increased glomerular capillary permeability and can lead to the development of nephrotic syndrome is what you need to remember. Then to call it as nephritic picture, if you do the urine examination, there should be hematuria, proteinuria with signs of ARF, that is azotemia and oliguria. To call it as nephrotic, urinary protein excretion should be typically more than 2 grams per deciliter is considered to be the important criteria. Because of that, there should be hypoalbuminemia along with hyperlipidemia. These are all the important features of nephrotic. Nephrotic will have edema, hypercoagulable state, tendency for infections, but there will be no hypertension. But hypertension and edema characterizes the nephritic syndrome. These 4 or 5 points, if you can write, you know all the differences. Now the second important type of glomerulopathy is the focal segmental glomerulosclerosis. Even focal segmental glomerulosclerosis also can present like nephrotic syndrome. You remember last time we discussed, when there is a minimal change disease or a membranous nephropathy, patients will have proteinuria, but never more than 3 grams or 4 grams. But if the proteinuria is 8 grams, 10 grams, 12 grams, 14 grams, patient is totally liquidated, then you should always suspect the possibility of focal segmental glomerulosclerosis is what need to be remembered. In addition to nephrotic syndrome, they will also have hematuria and hypertension. But the prognosis is poor, generally resistant to steroid therapy. Ultimately, they develop chronic kidney disease and they will die within 5 to 10 years with a progressive deterioration is what we need to fundamentally remember. Now, how do you induce remission if there is a nephrotic syndrome? We give steroids. अगर steroids का बात नहीं सुन रहे तो we will give cytotoxic agents like cyclophosphamide is what we will basically give. So half of the patients with FSGS with nephrotic syndrome, they will be ending up in requirement of cytotoxic agents for inducing the remission is what you have to ultimately remember. So this is a normal glomerulus, doctor. The blood with impurities is filtered, creating urine. This is the basic job of the glomerulus. If there is any HIV infection or if there is any IV drug abuser, in all these people there will be a scar which will be forming, and that lead to the atrophy of these nephron structures, and this is the fundamental pathophysiology of FSGS. Formation of a scar, decreasing the single nephron glomerular function is the underlying problem in the case of FSGS. That is the reason those who have posterior urethral valves, have you studied it in surgery? Posterior urethral valves. Normally what will happen, the ureters will join the bladder, bladder will be ending up into urethra. The urethral valves will prevent the reverse flow of the urine, but if the urethral valves are posteriorly located, there will be reflux uropathy. The urine will go from urethra back into bladder, bladder into the ureter, from ureter into all the way to kidneys, and kidneys get infected. Whenever they get infected, they develop a scar. Whenever they develop the scar, they develop FSGS. When they develop FSGS, it presents with nephrotic syndrome, which doesn't respond to steroids. So that is the whole chain of events. So what are you going to remember? Scar is the underlying, most important underlying pathological feature. Now, this is a classical histopathology. Why you want to do histopathology? Normally, if it is a minimal change disease, unless you are a foolish pediatrician, histopathology, renal biopsy is not required. If a diabetic individual presenting with nephrotic syndrome, you call it as diabetic nephropathy and you don't need renal biopsy. If we have to end up in doing renal biopsy for all diabetic patients, then you will have hundreds sitting in the OPD. But when a nephrotic syndrome patient presents with 12 grams, 14 grams, 16 grams proteinuria, first you should rule out that it is FSGS. It is not a simple nephrotic syndrome, it is FSGS, you have to rule out. Hence you need to do renal biopsy. If you do renal biopsy, is there any good news for the patient? No, it's a bad news. But still, how does the treatment differ? If it is a simple minimal change disease with normal glomeruli, steroids is okay. But if it is FSGS, then you need to basically think of cytotoxic therapy in order to manage the patient, is what need to be remembered. So these glomeruli show extensive abnormalities with the collapsed capillaries, with epithelial hyperplasia, which is very typical of what you call as FSGS. The next important glomerulopathy, mainly what you need to remember: HIV, reflux nephropathy, IV drug abusers, scar formation, severe form of nephrotic syndrome is equal to FSGS, bus, right? Next, membranous glomerulonephritis. Just like minimal change disease leads to nephrotic syndrome, membranous glomerulonephritis lead to nephrotic syndrome. But in addition, in membranous, why you call membranous? Why don't you call minimal change? In minimal change in glomeruli there is no change on light microscopy. But if you do light microscopy in membranous glomerulopathy, you find the glomerular capillary walls are thickened. Hence it is called membranous glomerulopathy, is what need to be remembered. What leads to this? Hepatitis C, hepatitis B, syphilis, malaria like infections, they lead to the thickening of the glomerular capillary wall and lead to the development of membranous glomerulopathy. Drugs like gold captopril penicillamine, and always remember, any elderly patient presenting with nephrotic syndrome should not be left home simply like that. Why? Because generally nephrotic syndrome is due to diabetic nephropathy. But he is an elderly person, let us say he has no history of diabetes but presented with nephrotic syndrome. He deserves a renal biopsy. If you do biopsy, you found glomerular capillary wall thickening. You called it as membranous nephropathy. Don't send him home. You check whether there is any internal malignancy that got undetected, because any elderly person presenting with nephrotic syndrome with a membranous nephropathy often will have an underlying malignancy which need to be identified. Generally it will be a lymphoreticular malignancy, is what need to be remembered. Okay, doctor.